Now let's see fluoroquinolones, which are safe in renal failure. They are not excreted by the kidneys, therefore they are least likely to be effective in UTI. See, a drug which is excreted through the kidneys that can be effective for the UTI, okay, urinary tract infection. If the drug is not excreted through the kidneys, that cannot be the effective for the urinary tract infection. The same thing which I am explaining here, that fluoroquinolones which are safe in renal failure, they are not excreted by kidneys, therefore they are least likely to be effective in UTI. The drugs which are not excreted by kidneys, they are safe in renal failure. Okay, the drugs include PMT, pfloxacin, moxifloxacin, and trovofloxacin, and this was the option given in the question. These are the drugs which are least likely to be effective in UTI. Now, what is tolerance? When same dose is not able to produce same effects. It occurs due to down regulation or desensitization of receptors. Example, opioids. If you use opioids like morphine for a long period of time, initially they can relieve the pain, they can cause analgesia. For long period of time, they cannot give you that feel. Okay, like opioids like morphine given or taken for long time can result tolerance. If opioid like drugs can use for long period of time, they can result in the tolerance. Okay, now remember nitroglycerin, it is a drug of choice for acute attack of angina. It works by releasing nitrous oxide. We know in the angina there are different types of angina. Actually, in the angina there is the narrowing of the blood vessel. Okay, if we cause vasodilation, we can treat the angina. For that we use nitroglycerin. It causes vasodilation by releasing nitrous oxide. Also remember, this nitrous oxide is going to increase cyclic GMP. It is going to increase cyclic GMP, and this cyclic GMP is responsible for vasodilation. Now let's talk about another important topic, that is Parkinsonism. It is a triad of resting tremors, rigidity, and bradykinesia. In the question, you will be given resting tremors, rigidity, and bradykinesia. Okay. Then, in Parkinsonism, there is degeneration of dopaminergic neurons in substantia nigra. It means when the dopaminergic neurons are degenerated, the dopamine will be less. Okay. In the Parkinsonism, the dopamine is less. But remember, acetylcholine is relatively higher than dopamine. Acetylcholine is not increased, but it is relatively higher than dopamine, because dopaminergic neurons are degenerated. Now, how we treat Parkinsonism? We can use levodopa plus carbidopa. They are most effective therapy for the Parkinsonism. We can also use amantadine. Amantadine acts by releasing dopamine. It acts by releasing dopamine. Actually, in Parkinsonism, we need dopamine. Na? So then what we can do is, amantadine also is used in antiviral for influenza. It's also used in antiviral for influenza. And the side effect for amantadine is ankle edema, which is reversible. And the important side effect which you need to remember is livedo reticularis. Livedo reticularis means pinkish pigmentation of skin in the form of a meshwork. This is livedo reticularis. As you can appreciate here, it is due to the amantadine. Now another class of drugs we can use, that is dopamine agonists like pramipexole and ropinirole. They are the drug of choice for Parkinsonism. Also, we can use anticholinergic drugs. I have told you that acetylcholine is relatively higher than the dopamine. So we can use anticholinergic drugs like benzhexol, which is also known as trihexyphenidyl. Remember, these anticholinergic drugs like benzhexol, they are drug of choice for drug-induced Parkinsonism. Benzhexol is drug of choice for drug-induced Parkinsonism. What does it mean, drug-induced Parkinsonism? It occurs due to some drugs like in the question you will be given history of typical antipsychotics like haloperidol, chlorpromazine, but mostly you will be given history of haloperidol. A patient is taking antipsychotic drugs like haloperidol. Haloperidol is D2 blocker. It means the dopamine action will not be there. We know in Parkinsonism there is dopamine deficiency. If you are blocking D2, the Parkinsonism will occur. Okay, this is the case you need to remember. Also, we can do deep brain stimulation in the Parkinsonism. You have to remember every point in the Parkinsonism. Now remember, PCM is safe in pregnancy. Paracetamol itself is not in safe in pregnancy, but it is a mnemonic PCM. Penicillins like amoxicillin, cephalosporins, and macrolides. Cephalosporins like ceftriaxone, okay, macrolides. Then trigeminal neuralgia. In trigeminal neuralgia, you will be given history of severe shooting pain on touching the face, during chewing, on speaking, and during brushing the teeth. Shooting pain, severe shooting pain will be the history on touching the face, chewing, speaking, and brushing the teeth. And the drug of choice for the trigeminal neuralgia is carbamazepine. Very important. Remember, oral steroids can lead to cataract, local steroids or eye drops can lead to glaucoma. A patient took some drug for the treatment of acute migraine attack. After this, she developed change in the color. She developed change in the color and numbness at the tip of the thumb. What is likely drug responsible, and what is treatment? What is treatment? See, this is the case of gangrene. A patient has taken ergot derivatives of drugs like in migraine we take some drugs like ergotamine, and that can lead to gangrene in a patient. That's why you can see here there is color change and numbness at the tip of thumb, and the drug responsible is dihydroergotamine, which is used in the migraine. And for the treatment we can use a vasodilator known as sodium nitroprusside. Now let's see some toxins and their antidotes. First one is acetaminophen, that is paracetamol. Paracetamol. And the antidote is N-acetylcysteine. Digoxin antidote is digibind. Beta blocker or calcium channel blockers antidote is glucagon. Tricyclic antidepressants antidote is sodium bicarbonate. For local anesthetic toxicity like lignocaine, lidocaine, or bupivacaine, the antidote is 20% IV intralipid. For opioids, naloxone IV. For benzodiazepines like diazepam, antidote is flumazenil, but it is controversial. It is not used in the clinical practice because it can lead to seizures. Methemoglobinemia, antidote is methylene blue. For iron, deferoxamine, very important. In the question you will be given a child has taken lot of iron tablets. What the antidote you are going to give? The antidote you will give is deferoxamine. For carbon monoxide poisoning, you will give hyperbaric oxygen therapy. For ethylene glycol or methanol poisoning, you will give fomepizole or IV ethanol. For OPC, organophosphate poisoning, you will give atropine. Also, you can give pralidoxim. For cyanide poisoning, you can give hydroxycobalamin as an antidote. Now, let's see what is physiological antagonism and what is pharmacological antagonism. See, physiological antagonism acts by different receptors produces opposite effects. You can see different receptors, different effects. For example, histamine and adrenaline. Histamine and adrenaline. Histamine acts on H1 receptor, results bronchoconstriction. Adrenaline acts on beta 2 receptors, results bronchodilation. As you can see here, receptors are different receptors, and the effect is also different. Effect is opposite. This is called as physiological antagonism. Then look at pharmacological antagonism. They act on same receptors, produces opposite effect. For example, adrenaline or beta blocker like propranolol. Adrenaline acts on beta 2 receptors. It is beta 2 agonist. It results bronchodilation. Propranolol is beta 2 blocker. It causes bronchoconstriction. Now see, the receptors are same. The receptors are same, but the effect is opposite. Opposite effects. This is the pharmacological antagonism. Drugs causing gynecomastia are remembered with disco drugs. D for digoxin, I for isoniazid, S for spironolactone, C for cimetidine. You can also remember ketoconazole, O for estrogens. Drug of choice for chemotherapy induced nausea and vomiting. Drug of choice for chemotherapy induced nausea and vomiting are 5-hydroxytryptamine 3 blockers, that is cetron drugs like ondansetron, palanosatron. Also, if there is delayed nausea vomiting due to chemotherapy, the drugs which we can use like dexamethasone, dexamethasone, aprepitant. These drugs can also be used in the chemotherapy induced nausea and vomiting if it is delayed. Okay. Drug of choice for mountain sickness is carbonic anhydrase inhibitors like acetazolamide. Very important. Drug of choice for motion sickness is hyoscine, which is also known as scopolamine. Drug of choice for morning sickness is doxylamine with B6. Okay. Drug of choice for morning sickness is doxylamine with vitamin B6. Remember very important points about B6, that it is used for isoniazid overdose. Isoniazid is a anti-tubercular drug. If it is overdose occurs, we can give vitamin B6. Okay. Also remember, peripheral neuropathy can occur due to isoniazid Peripheral neuropathy can occur due to isoniazid because isoniazid can lead to vitamin B6 deficiency. Now, as you can see here, at high altitudes like Leh Ladakh, the partial pressure of oxygen decreases that can lead to hypoxia. Therefore, once the hypoxia has occurred, that is called as mountain sickness. Now, what is the treatment of mountain sickness? The best treatment is, if possible, descend downwards. If not possible, give oxygen to the patient, and the drug of choice is carbonic anhydrase inhibitor, that is acetazolamide. For severe cases of mountain sickness, start steroids like dexamethasone. Now, remember, drugs ending with "ide" can cause hypoglycemia like glipizide, repagilinide, tolbutamide. They are sulfonylurea. Okay, drugs ending with "ide" they can cause hypoglycemia like glipizide, repagilinide, tolbutamide. Also remember, insulin can also result hypoglycemia. Now, very important drug, that is metformin. I want you to remember every point about this drug. It activates AMP kinase enzyme. Once this AMP kinase activated, once this AMP kinase is activated, then what are the effects of this enzyme? It's going to inhibit gluconeogenesis. Sorry, it is going to inhibit gluconeogenesis, glycogenolysis, but it is going to stimulate glycogenesis, formation of glycogen. It is going to stimulate glycolysis, breakdown of glucose. By these mechanisms, metformin is going to decrease the blood sugar but does not cause hypoglycemia. It means the metformin is a smart drug. It decreases the blood sugar, but in such a way it decreases the blood sugar that it cannot cause hypoglycemia. Okay, it is drug of choice for type 2 diabetes mellitus. Also remember, it is responsible for maximum reduction of HbA1c, okay, glycated hemoglobin. Also remember, it causes weight loss. Another side effect of this drug is, that is, lactic acidosis. Also remember this side effect also. Now, what are incretins? They are normal physiological substances which are released in GIT after food. They are normal physiological substances which are released in GIT after food intake, and stimulates release of insulin. They helps in release of insulin and therefore controls blood sugar. Incretins control blood sugar by releasing the insulin. And the example of incretin is GLP, glucagon like peptide. This is the example of incretin. Okay, this glucagon like peptide increases insulin secretion and controls the glucose level in the blood. As you can see here, this glucagon like peptide after some time is degraded by an enzyme known as DPP4, dipeptidyl peptidase 4. It is degraded by this enzyme. Okay, it becomes inactive. Now see, what you can do is, if you want to increase the insulin, you can give analogs of this substance, analogs of this GLP, or you can inhibit this enzyme. Once you inhibit this enzyme or block this enzyme, the GLP will not be degraded. Okay, it will not be inactivated. Its level will increase and therefore it will increase the insulin. These drugs are called as incretin mimetics. The incretin mimetics include GLP analogs like exenatide or liraglutide? This was the question asked. Which of the following is GLP analog? What are the DPP4 inhibitors? Dipeptidyl peptidase 4 inhibitors. They include sitagliptin, vildagliptin, linagliptin. Very important. DPP4 inhibitors are contraindicated in renal failure except linagliptin. Except linagliptin, because linagliptin does not require dose reduction in renal failure. It does not require dose reduction in renal failure. You can remember linagliptin लेना ही है renal failure में. Okay. Now we have another class of drug, that is SGLT2 inhibitors, sodium glucose transporter 2 inhibitor. In the proximal convoluted tubule, this is the PCT. Okay. In the proximal convoluted tubule, we have this transporter SGLT2. Once the glucose is filtered, this glucose is reabsorbed through this transporter. Not only glucose, sodium as well as glucose is reabsorbed through this transporter. Now what we can do is we can we can block this transporter. If we are blocking this transporter, the glucose will be thrown out through the urine. Okay. The drugs include canagliflozin, dapagliflozin. How to remember? Glucose flows in urine. Glucose flows in urine. Important side effect which you need to remember is urinary tract infection due to glucose urea, because once the glucose comes in the urine, this glucose can attract the infection. Okay, that's why the UTI can be seen in SGLT2 inhibitors.